So I'm going to be talking today about one of the things that I seem to look at quite a lot in clinic. And when I thought about what my clinical goal might be, I was one day just looking at some video gait analysis and pressing my cursor through and through the video and thinking, what am I actually looking at? And this is one of the things that I seem to be looking at, is looking at gaits, the gait cycle as a whole, and one particular part of that, which is what I'm going to talk about today. But generally speaking, as podiatrists, what is it that we're actually trying to do? So are we fixing pronated feet? Are we fitting arch supports? And what are our objectives in this? What is it that we would consider a good outcome? So one possible answer to this is that I would argue that we're trying to normalize foot function to some degree, rather than looking particularly just at static alignment. But obviously, the foot in itself is an extremely complicated structure. It is structurally different from person to person, as is the rest of the body. And then the movement that patients are applying to it is also different. So most of our patients are doing things like this. They're running, they're walking, they're moving around, applying different load. And so each individual person's biomechanics are going to be very, very different. And so their individual pain is going to be happening for a different reason. So static alignment and static assessment, whilst it has its advantages to look at, for instance, the effect of tibial varium and how the foot is compensating for that, we do probably need to be looking at these things more dynamically, and we need probably to have some sort of very basic gait analysis or kinematic analysis to be able to establish what is actually going on if we've got any hope of actually being able to try to change it. So within clinic, what I seem to be doing is looking at the gait cycle and then particular aspects of that gait cycle. In order to do that, we need to be incorporating some video at the very least. So to look at normal function, we need to see also what is changed function, but to assess normal function, we need to be able to see it. So at the very basic level of this, we have the gait cycle, which we're all very familiar with. It's worth saying, though, that in certain disciplines, and we'll all be very familiar with this particular gait cycle, the gait cycle is described a little bit differently. And I attended a clinical gait analysis course recently in Salford, which is a non-podiatric education session, and they were even arguing that at the propulsive phase of gait, it could be argued that that is actually deceleration. So there are arguments to be had within the gait cycle, but as we understand it, essentially, first part of the gait cycle during stance phase, so up to about 50% of that phase of gait, the foot is acting as a mobile adapter as the leg internally rotates to absorb shock. And then we would generally accept that towards the end of stance phase, the leg is externally rotating, the foot is going into a supinated position to act as a rigid lever. And it would seem in my clinics that there seems to be far more of my patients that have a problem with their foot not returning to being a rigid lever than being a mobile adapter, although absolutely it is more difficult to turn a foot from being a rigid lever into a mobile adapter. But mostly what we see coming through is people not getting back into that propulsive phase. So there's two little tests that I seem to do routinely, I'm not sure what other people are looking at, that seem to look at this very specifically, and they're very easy to do in clinic, particularly if you're videoing them. So one of them is tiptoe test, which we probably all do, but it has lots and lots of different aspects to it that can easily be incorporated to an assessment of what is going on inside the foot. So here on the left-hand side, you have a normal tiptoe, as near as normal you can ever get anyone to be. And we would all know that you need to get the heel off the ground to have a normal tiptoe, particularly single leg tiptoe, and that the foot at the back, so the rear foot, needs to invert and come back into alignment with the leg. But there's countless other things going on here which are really descriptive and informative as to the makeup of this foot. So in order to perform this movement, you need to have intact major plantar flexor muscles, so Achilles tendon and tibialis posterior. The subtalar joint needs to go into a supinated position. Mid-tarsal joint needs to rotate back round and pronate. The first metatarsal needs to plantarflex. First metatarsal phalangeal joint needs to dorsiflex. You get reformation of the transverse metatarsal arches and also the other arches of the foot. You need to have at the very least a partially intact plantar fascia, intact spring ligament, and also intact neuromuscular action. So there's a lot that needs to go on there to perform that movement. And you can see on the right-hand side, this video shows what can happen just with a very simple change to the foot. So an altered metatarsal parabola means that the rear foot is going back into alignment with the leg. But actually, once she goes up onto tiptoe, mid-tarsal joint isn't rotating, bringing the foot down to the ground. There's no reformation of the transverse metatarsal arch. And so she's getting pain plantally to her first metatarsal heads, which is really no surprise. So we're just doing a really simple test, one single assessment. You can get an idea of why that patient might be having that pain. So then the other assessment that I do, generally speaking, is just really basic gait assessment. And so in this phase of gait, if you compare the tiptoe, we're looking for what the patient is doing at the propulsive, so to speak, phase of gait. We would expect the foot to be turning back into that tiptoe position. So in this case, this patient actually used to have a stage 2 adult-acquired flat foot, but you can see that this is a relatively normal tiptoe. So when she first presented to treatment, she wouldn't be able to do any tiptoeing at all. But during the gait cycle, she doesn't have that propulsive position at all. And so this highlights some of the external factors that could be influencing what is, ordinarily speaking, a normal tiptoe and making it go into an abnormal position during walking. So the main ones of those are a lack of external hip rotation or, for instance, femoral anteversion. So OA hip is something that I see quite routinely, stopping the leg from externally rotating and preventing this push-off position. And also leg length discrepancies, scoliosis, tight calf muscles. But in this patient's case, it was quite significantly her very, very significant hypermobility, which was massively unlocking her midfoot and creating a big functional hallux limitus, but also an inadequately strong tibialis posterior as a result of the previous condition that she had. So once you know those two things, you have more of an idea of what's going on inside the foot, potentially structurally and functionally, what's going on outside of the foot, and how this is going to be changing the patient's gait pattern. Then what can you actually do about it? What can you change? What can't you change? How are you going to change it? And who is going to be doing the changing? Is it going to be you doing the changing from the foot up level potentially, if you're using orthoses, gait retraining? Or are you going to be incorporating some other members of the multidisciplinary team to achieve this? So like in this case, this is quite an obvious case of a significant femoral anteversion. And this lady really needed to have derotational osteotomies, which her parents didn't want her to go ahead with. So in reality, this is going to be her gait cycle throughout life. So she has orthoses, which are helping her knee pain, but we're never going to address the cause. So she can maintain her flexibility with physiotherapy, but fundamentally, this is always going to remain the same. So just an example of what we do at foot level potentially, or certainly what I look at in clinic once I've done something at foot level, is if I've intervened with orthoses. So if I've identified this lack of propulsion in gait, and I've found something within the foot that I can change, and I've done that with an orthotic, I would then, when I see them back, expect to see a difference at propulsion. So the before picture shows how her foot is not coming back into alignment with her leg. She's not re-supinating at the subtalar joint and coming back round and fixing that foot back into a rigid position. The influencing factors in this case were that she had really tight hip flexors because she was a really enthusiastic rower, tight calves, shorter first metatarsals, and a genu valgum. You can see in the after picture that her knees are in a much better position. She's less valgum, and she's closer together on the treadmill in terms of the alignment of her feet. And also, obviously, we had to change her trainers because her trainers were terrible. So there's other influencing factors. But in this particular case, she was pain-free after day 1 of using the orthosis, which is quite unusual. But this is a significant outcome. So this is a functional change. And I think something we have to be careful of in podiatry is some professions, in particular ones that we work very closely with, sometimes think that orthoses are weakening. And to me, they're not weakening if they're done properly. They're dynamic and they change function. And this is a very simple objective measure of that functional change. So I would argue that they're actually strengthening rather than weakening our patients. Now, sometimes you can do a lot to change function, and you can be effective with that, and you can get on top of certain conditions, but sometimes there's just things that you can't change, and the patients really have to engage with this. So these are more the external influences on gait. So in this patient, she had very, very significant chronic ongoing medial tibial stress syndrome, which we've got on top of with what must be the world's most controlling pair of orthoses. They're really quite embarrassingly really rigid. And her anterior knee pain has improved, but her pelvic position is all over the place still. She's got significant Trendelenburg and significant femoral anteversion as well as it happens. But at some point, she's going to have to engage with the process of strengthening her glutes and changing her gait cycle, which Whenever we bring it up again and again with her, she'll say, yes, I realise that and I need to get on top of that. But realistically, she hasn't done this consistently. So she's now currently getting hamstring pain, which now really is the final stage where she has to start bringing more hip extension into her gait cycle and improving those glutes. But these are examples of external causes, some that you have control over and some that you don't. And a lot of the time that you have to involve other professions to try to help with. So this girl really needs a good onboard physiotherapist that's going to help her through this. And you're not going to be able to do all of this yourself potentially. So just in summary, in terms of certainly what I do in clinical practice, is I try to identify the dynamic cause of someone's pain, I try to change it, and then I try to see if I've changed it. I think we need to all make sure we're working in multidisciplinary teams, as that seems to be the best way forward in terms of success. Thank you very much.